Good morning, good afternoon, good evening from whichever part of the world you are from. Welcome to the first series of epilepsy surgery case by case, step by step, which is being done by the Commission of Asian and Oceanian Affairs, a part of International League Against Epilepsy, which is part of AO-ILAE. On behalf of my co-convenor, Professor Kensuke Kawai, Chairman of the AO-ILAE, Professor Akio Ikeda, Secretary of the AO-ILAE, Professor Dunne, I welcome all of you for the first series of this show. So once again, welcome to all of you. This program has been pending for a long time and has arisen as a result for the need to provide a step-by-step, case-by-case learning experience to people and faculty and residents, especially from the Asia-Pacific area, where they have little or no access to epilepsy surgery. As we all know, there is a huge gap for epilepsy surgery in terms of what can be implemented and what needs to be known. And one of the purpose for this webinar series is to attempt to close that gap. So today we have three extremely renowned faculty joining with us, and we look forward for a very nice session. So on behalf of myself and my co-convenor, Professor Kawai, I would provide a brief introduction to my esteemed co-convenor, who is very highly qualified. So Professor Kawai is a professor of Department of Neurosurgery from Jichi Medical University, Vice Director of Jichi Medical University, Japan. He did his education from the University of Tokyo. He did his post-graduation from the University of Tokyo Hospital under Professor Takakura. And then he has been a visiting fellow and staff neurosurgeon for a number of universities, which include the stroke branch of NINDS, Teruoka Memorial Doctor Hospital, Tiko University Hospital, the University of Tokyo Hospital. He was then a staff neurosurgeon of the Epilepsy Group, Department of Neurosurgery from the Tokyo Metropolitan Neurological Hospital. And then he was an assistant professor in the University of Tokyo, Department of Neurosurgery, became an associate professor, and then the director of Department of Neurosurgery from NTT Medical Center, Tokyo. And currently is a professor and director of Department of Neurosurgery from Jichi Medical University. He also happens to be the co-chair of the epilepsy surgery subsection of the AO-ILAE, which is Asian Oceanian component of the International League Against Epilepsy. And together, both of us, we have started this exciting new series. And that's briefly about me. I'm a professor from All India Institute of Medical Sciences, Department of Neurosurgery in New Delhi. And now it's my pleasure to introduce the leadership of AO-ILAE, Professor Akio Ikeda, who is the president of Japanese Epilepsy Society. He is the chair of Commission on Asian and Oceanian Affairs of the International League. He is a professor of Department of Epilepsy, Movement Disorders and Physiology in Kyoto University, Graduate School of Medicine, Japan. Aside from his teaching and clinical roles, he is involved with numerous professional bodies. He is an incumbent EXCO member of Japanese Society of Clinical Neurophysiology and holds various council and committee members positions in Japanese Neurological Society. He has been working on clinical epilepsy, wideband EEG, and the role of GLIA in epileptogenicity, and earned his PhD from Kyoto University in 1993 with his thesis on movement-related potentials recorded from the supplementary and primary motor areas. He has published very widely, and some of the highest cited publications, has close to 400 publications, and he is currently, of course, a chair of the AO-ILAE, and we are really grateful that he could be there with us today. Professor Dunne is currently the secretary for the AO-ILAE. He is from Australia. He is graduated from the University of Western Australia from Clinical Neurophysiology, EEG, Epilepsy Fellowships at Mayo Clinic. He is currently the professor, Department of Medicine, University of Western Australia. Secretary, he is currently, of course, the Secretary General for the ILAE Asia Oceania League. He is a chairman, Western Australian Epilepsy and Adult Clinical Neurophysiology Services. He is a member of Epilepsy Society of Australia, National Executive and other committee. He is the author of over 100 well-cited peer-reviewed publications. He has been awarded the Asian and Oceanian Outstanding Achievement Epilepsy Award in 2014, and then the prestigious Ambassador for Epilepsy Award in 2019. He is involved in epilepsy, clinical neurophysiology, teaching throughout the Asian and Oceanian regions. Both him and Professor Ikeda have been one of the key forces which led to the realization of the current series of webinars. Now, before I proceed further, I will now request Professor Ikeda to say a few words. I will stop sharing. So, Professor Ikeda, as a chair, would you like to speak a few words?
Thank you very much, Professor Chandra. On behalf of the AIIMS Asian Oceania, it is my great honor to give some words before the first launching of this very distinguished the webinar called Epilepsy Surgery, Case by Case, Step by Steps. That's actually the plan by the Epilepsy Surgery Task Force Chair, Co-Chair of Professor Sarat Chandra and Professor Kensuke Kawai, which enable us to have the great opportunity to discuss that the very difficult cases which could be encountered in each country and each institute. So the discussing together will bring us at the very good idea in the current situation in the very near future. So therefore, although the COVID-19 is now actually impeded many things, but this kind of web seminar would enable us to expand that our connection throughout the world. Fortunately, on this occasion of the launching the seminar, we have the distinguished guest for a discussion. So we very much looking forward to a fruitful discussion. So and again, that I really appreciate for all the contributor of this one, including Professor Manjari Tripathi or the other person, and also especially a distinguished guest from Sao Paulo. So thank you very much for having this kind of discussion.
Thank you so much, Professor Ikeda. It was a pleasure having you here. Now, for this webinar, currently I have been given a message that we have had more than 800 participants, practically from every part of the country, starting with Afghanistan, and we have almost participation from every country of the Asia Pacific, and we look forward for a very nice webinar. And before we start, I will request my co-convenor, Professor Kensuke Kawai, to say a few words.
So the last month, we had Asian Oceanian Epilepsy Conference. And in that conference, I presented on behalf of the Epilepsy Surgery Task Force about the current status of the epilepsy surgery in Asian Oceanian countries. And this is a conclusion slide. So our conclusion was there is a big surgical treatment gap in Asian countries, particularly in low-income countries, and the use of epilepsy surgery varies throughout Asia. And we don't have reliable data on current status of epilepsy surgery. And members of AO-ILAE requested to collaborate for promotion and the utilization of epilepsy surgery in our region. And so our task force, the aim is here. So we have been planning actually the seminars in countries where resources are still limited, like Bhutan, Nepal, and Mongolia. And also a survey on the current status and the building up an epilepsy surgery database. Actually, Professor Lim from Malaysia today proposed us about using their database system for epilepsy surgery database. And anyway, so today's webinar is one of the kind of trial for this target of seminars, other seminars in countries where resources are still limited. And unfortunately, it was held in this like webinar on web. But actually, it is not unfortunate. It is fortunate because I heard the registration number of registration was actually 700. That number is much more than the actual, the meeting. So I think I really thank Professor Chandra to organize this first webinar, and I'm really looking forward to hearing the presentation and making my contribution for that the distribution of the knowledge and experience. Okay, thank you very much.
Thank you very much, Professor Kawai. I will just read the list of countries which are participating in this webinar. Afghanistan, AU, Australia, Bangladesh, Brazil, Burkina Faso, Cameroon, Canada, China, Egypt, Georgia, Hong Kong, India, Indonesia, Iran, Iraq, Japan, Jordan, Malaysia, Mauritius, Myanmar, Nepal, New Zealand, Oman, Uruguay, Pakistan, Peru, Philippines, Qatar, Romania, Saudi Arabia, South Korea, Sri Lanka, Switzerland, Syria, Taiwan, Thailand, Togo, Tunisia, UK, UAE, United States, Vietnam, Yemen, and Zambia. So welcome to all the delegates from all the countries. I hope you will find this very, very useful. Professor John Dunne could not attend this. I have a short video from him, which
Dear colleagues,
send it.
my name is John Dunne from Perth in Australia. Together we face many challenges, but our goals remain the same. These include providing the best support and care to people with epilepsy. For some patients with epilepsy, surgery delivers the best treatment outcomes, but epilepsy surgery is underutilised, especially in our region. The International League Against Epilepsy recognises this, and in our region we are very fortunate to have P. Sarat Chandra and Kensuke Kawai lead the Epilepsy Surgery Task Force, aiming to increase knowledge and capabilities regarding epilepsy surgery and its delivery. They are great leaders and, amongst many initiatives, have convened this meeting. Epilepsy surgery, case by case, step by step, commencing this evening with mesial temporal sclerosis, with the help of an excellent team of experts and friends from India and Sao Paulo in Brazil. Together we can achieve so much, whatever challenges we face. I hope that you will find this important educational initiative helpful and enjoyable, and ultimately assist patient care. Thank you.
Thank you, Professor John Dunne. A small slide. This program would not have been possible without an unrestricted educational grant from IPCA, and we thank our sponsors for creating this program for a full year and maybe more. So I will now request Dr. Manjari to present clinical history and semiology. So Manjari is a professor of neurology at the All India Institute of Medical Sciences. She is in charge of the Center of Excellence for Epilepsy and the MEG Resource Facility. She was awarded the NIH Fellowship Epilepsy at UCLA from 2005 and 6, and also the Penry Fellowship in Epilepsy from Wake Forest University. She is alumni of the San Sarolo Epilepsy School. She was awarded the Asian Oceanian Outstanding Achievement Award in 2016. She is an AIILAE Task Force member for Stigma in Epilepsy, Pediatric Epilepsy Surgery Subcommission, Neurosciences Task Force member of Department of Biotechnology, Ministry of Science and Technology for Epilepsy, and also heads the Disability Task Force for Epilepsy. She is the coordinator for National Epilepsy Control Program from India along with Ministry of Health. She is the Secretary General of Indian Epilepsy Society and member of IEA and core committee for guidelines of epilepsy management in India. She has 318 research publications, including the first ever randomized controlled trial, which is very well cited for drug-resistant epilepsy in children. She has trained several PhDs, neurology residents, and NHM workers. delivered more than 200 guest lectures and orations. The main areas of interest are epilepsy, especially drug refractory epilepsies, epilepsy surgery, women and epilepsy, functional neuroimaging and epilepsy, sleep disorders, cognitive and autoimmune disorders. She is a national course director of epilepsy and EEG workshops, which was started by Indian Epilepsy Society, and it was initiated by her. She also runs a rural outreach program of epilepsy in tribal areas of India, particularly the eastern and the northeastern part, and organizes several epilepsy awareness and has written patient handouts, and also is a director for an epilepsy patient support group called as Ekatvam. So Manjari, can you please go ahead?
Thank you. I would at the outset like to thank the Asiano-Oceanian region and the members of the task force and the CAOA for having me present this first case. Now, the case is pretty much very simple. So we are going in the retro. We first present the case, and then we discuss it with the eminent international faculty. So I dive straight into the case, and here is a young man who came to us, with a long history of seizures. So basically, when he was very young, at the age of 2 years, he had very high fever and associated with seizures, which, according to the history of what the parents remembered, looked like generalized seizures during and following the febrile illness. And these recurred from an age between 2 to 3 years. And then suddenly there was a period of quiescence. And for these episodes, as was in those days, he was put on phenobarbital, which was later tapered. Of course, now we know that we would manage these seizures with SOS, clobazam, and antipyretics. Then he was seizure-free for 10 years. So he had a complete, education. And however, at about 12 years, while he was in school, he had a recurrence of seizures, which are pretty much different from those which occurred in his childhood. And the frequency of these was initially very less. It was about 1 to 2 a month. But by the time he came to us at the age of 40, it was about 1 to 2 per day. Now, apart from the antecedent history of fever, there was no history of any head injury or any encephalitis or any other family history or anything like that. With this, when we looked at the semiology in the outpatients, he definitely gave us a history of an uncomfortable sensation in the upper stomach. And this was followed by some nervousness. And he would call his relatives. And then there were some movements of his hand. And the caregiver, being extremely observant, told us that they were coming. These movements were mostly in the right hand. And then he would not respond for some time. And according to them, the maximum duration of the seizure could have been about 20 seconds and sometimes maybe longer. Now, before coming to us, he was about 40 years old. He had several years. So right from 12 years to now, he's been having several anti-seizure drugs. And currently, when he came to us for the evaluation, he was on 4 drugs. And they were on good doses, particularly levetiracetam, which was, on a 3-gram dose, and valproate also, which was on a 1-gram dose, and oxcarbamazepine, as well as clobazam. But his seizures continue to occur very frequently by the time he came to us. In his life, though he had his education interrupted, he was, doing a small-time job at a local shop. So he was he was working, but it was a severely disrupted, work atmosphere. And because of the seizures, he was never given any responsibility. So now I go on to of course, this patient fitted into the International League Against Epilepsy's definition of drug-resistant epilepsy because, look at the treatment gap here. He has come to us after so many years of unabated seizures. We decided to fast track him into the epilepsy monitoring unit because we knew that this was probably the most fruitful of outcomes for epilepsy surgery if he had the pathology that we suspected and if his seizures were coming indeed from that pathology. We always take consent for using the videos for educational purposes. However, for the purpose of this presentation, we have muted his name during the video. So you will hear the video, but it will be muted. Before the video, EEG, that is in the epilepsy monitoring unit, his outpatient interictal EEG clearly showed us right anterior temporal spikes with equipotentiality in the right anterior temporal electrodes. So this was the interictal EEG. Going on to the semiology, he indicates an epigastric aura, and they realize he's having a seizure. You can see the left hand is actually covered by the technician, but it's not moving much. Then he starts having, the left hand is still a bit twisted, then he starts having automatic, repeated, repetitive movements of his right upper limb, which appear pretty stereotyped, and he has a glance. He has glance to the right. So he's kind of looking to the right, but he's not versed to the right. He's not forcefully turned to the right. And these repeated stereotypies continue. He is not responding to the questions the technician or the nurse is asking. There are some artifacts because he's sitting right on the cable, so the technician is trying to correct that. And then, of course, he's trying to move his right lower limb too, a bit restless now. And we did notice that initially his left upper limb was relatively immobile. RI is relatively immobile, and there was a suggestion of. Then he starts having oral automatisms. So you can see the oral automatisms. And then he kind of turns 180 degrees. So he'd had non-forced eye to the right. He did not have a forced version to the right. And he turns 180 degrees to the right. And his oral automatisms pretty much continue. And then he spits. So he spits that 180 degrees. Still not responding. And he's restless. It is pretty much a very prolonged event. The technician is trying to ask him to name things. Kind of touches his nose, but not really a nose rub. And he tries to leave the bed. So he has a periictal leaving behavior. So he has a PLB, which is a periictal leaving behavior, almost tries to jump out. And towards the end of the seizure, he talks. So you can hear him talking and trying to get off. And he tries to walk out with the. So basically, as a clinician neurologist, one would like to analyze his symptoms. The first indication he gave to us of having the event by telling the technician around him is that he has some peculiar sensation in his abdomen, which he did with his hand, right hand. And we know that about up to 60% of people with temporal lobe epilepsy will have this very, very characteristic abdominal aura. And it is less common. It's only in up to 20% in the extra temporal lobe events. There's no significant difference of this abdominal aura between the dominant and the non-dominant temporal lobe. And the presence of this aura strongly points to the mesial temporal origin of the seizures. It indicates stimulation of the visceral networks involving the anterior insula, amygdala, and the orbitofrontal area. And the amygdala is at the core of this network, as is the expression of fear in temporal lobe seizures, though he did not have fear. Then, of course, he has repeated stereotyped automatisms of his right upper limb, and these are very repeated and they last for some time. Now, this is also very characteristic. If it's a unilateral automatism, it's likely to be ipsilateral. So the automatism repeated was ipsilateral to the right. This was the stereotyped automatism. It wasn't a reactive automatism like trying to continue doing the activity which is ongoing. It was more of a stereotyped automatisms, and the automatisms all obviously involve and originate, due to stimulation of a network, and this network, spreads from the area of the onset of the seizures to involve the cingulate, anterior cingulate cortex. So that's the mechanism of the upper limb automatisms. Then we noticed he had buccofacial automatisms, and these buccofacial automatisms were described as early as 1954 by Penfield and Jasper by direct electrical cortical stimulation to be arising from peri-insular temporal cortex, amygdala, and hippocampus and anterior commissure. The basic mechanism is an activation of specific brain areas or the release of certain areas from centers of inhibition from higher cortical centers. So it's either an activation of certain areas or a release of inhibition of certain areas. They can be de novo or they can be a reflex change to, sense of perceived taste. So basically, he had these oral automatisms, which could be a disinhibitory phenomenon, and we saw them clearly. Then he also had ictal spitting, which is not very common. It's not always seen in the epilepsy monitoring unit. It's only seen in about 0.3%. And the mechanism is somewhat similar to the oro-elementary automatisms. Again, it could be a release phenomenon from centers of higher control or a cortical activation, and it may be a learned behavior. He also had a 180 degrees turn. He had a 180 degrees turn on the bed without forced version of the head preceding it or forced version of the eyes preceding it. That is, in seizures, without a preceding forced version of the head, the direction of the rotation is towards the side of seizure network. So he rotated himself towards the right. So this would again be of lateralizing value. Then he had peri-ictal leaving behavior. He tried to get out of the bed and go out with the junction box in the monitoring unit. Now, this is also coming from the non-dominant hemisphere and involves the spread and involves the network in the spatial and topographic centers which are situated in the posterior parietal, non-dominant region. So again, lateralizing it to the non-dominant cortex. When we looked at his ictal EEG, you can see here, he's blinking pretty much before the event, and this is a bipolar double banana montage. And you can see here pretty much that towards the end of the page, there is some slowing which comes in the anterior temporal. T2 is the anterior temporal electrode, which we put the extra one. And if we go to the next epoch, it is involved into a beautiful rhythm, which is initially delta. So it is 1, 2, 3, 4 per second. So kind of delta. And then the delta involves into a phase reversing rhythm. Again, reversing in the anterior temporal T2 here. So you can see it's become a little faster than the onset of delta. So it is evolving into a kind of theta. It is evolving not only in frequency, but also in amplitude, suggesting that this is indeed an ictal phenomenon and not an artifact. And you can see it increases further in amplitude as it goes on. The left side has then caught up with these phase reversals. And however, the amplitude and the rhythm is better defined over the right regional area with continuing phase reversals towards the end of the seizure, as we can see here. So discussing briefly about ictal EEG and TLE, we know that the ictal EEG in TLE, which is mesial in onset, is pretty characteristic. And in about 80% of people, you will get a good localization provided it's a mesial temporal lobe. You can get a false lateralization in about 3 to 13% of people, which is known as, a burnt out hippocampus actually manifesting on the other side. In about 5% of people who have particularly only aura or little, brief seizures, you may not actually find a ictal EEG change. So that does not mean it's a pseudo seizure. It may be that the patient belongs to that 5%, provided the seizures are pretty characteristic of the mesial temporal and the interictal EEG is showing these phase reversals in the temporal, anterior or mid-temporal regions. Now, the non-invasive EEG of the hippocampus has basically two patterns, the 1A and the 1B and the 1C, which is a combination of 1B followed by 1A. So what is this 1A? The 1A pattern is an inferior temporal pattern, and starts at about 5 to 9 hertz and is regular for at least 5 seconds or longer. Whereas the 1B is a little higher. It's the vertex region, starts at 5 to 9 hertz, and this 5 to 9 should last for at least 5 seconds. And the 1C is 1B converting to 1A. The temporal neocortex pattern, which we will see in subsequent cases, is slower. It is 2 to 5 hertz. So you can see here the 1A pattern, which is typically the 5 to 9 hertz, which you can see here, and evolving further. And the 1B pattern, which is not only seen in the temporal region, but there is some slowing seen towards the vertex, towards the central region. And you can see the rhythm also coming in the central region, apart from the vertex region, apart from the temporal region. So I'd conclude by saying that as a neurologist, looking at the epilepsy monitoring unit and the interictal EEG and the semiology of this patient, we can develop a hypothesis safely that this patient has ictal onset zone coming from the right mesial temporal region because of unilateral automatisms of the right upper limb, followed by a 180 degrees turn, also a relative immobility of the left upper limb, also an ictal spitting, and of course, return of speech immediately after the seizure was over. We didn't see the contralateral characteristic dystonia, but relative immobility is also a strong sign and will be discussed further. For all those participating and those who are beginners, I suggest 2 landmark articles which are published for semiology by Nancy Foldvary and by Prakash Kotagal and Loden Kemper. Both appeared in Epilepsy and Behavior in the year 2009 and 2005. These are available for free download on the net, and you can read almost all semiologies on this. With this, I'd conclude my part of the evaluation of this case. Thank you.
Thank you, Manjari. So, Cristine, would you like to comment anything on Manjari's presentation? A couple of comments.
Okay. Yes, I think that is very, very nice case because it's very it's good to talk to teach, because as Manjari mentioned, so the patient has the speech in the middle of the seizure and the rapid return. So everything points to the right side in the semiology, and mostly the automatisms, unilateral automatisms, as all the immobility of the left hand, left arm. So he didn't have the dystonic posture, but he had the immobility. So I think that is very, very, very nice to show that points to the right side, and also the EEG.
So there is a question from an audience. I think we can take one question. So it's for both Cristine and Manjari. So it's from Dr. Vaishnavi Gupta. She is asking, is it a temporal or a parieto-occipital seizure?
I think her question is justified because towards the end he has this periictal leaving behavior. Now, the ictal onset is marked by an epigastric aura. And this is followed by unilateral automatisms. This is followed by oro-elementary automatisms. This is then followed by a ictal body turn and ictal spitting, followed by late, and of course the relative immobility is there in the beginning. So all these features would suggest that the seizure onset is the mesial temporal lobe on the right. Now the network and the spread towards the end of the seizure has involved a wider network involving the posterior area, the temporal parietal junction, which is the non-dominant cortex, explanation for the periictal wandering or leaving behavior. So Cristine, is this correct? Is my explanation?
Yes. I think so. Yeah, actually, sure, because you have to, you need to see the initial features, and then the spreading. So this behavior in the end is totally linked to the spreading of the seizure, and not for the initial onset.
Thank you.
So before we go to imaging, I have a question to both Manjari and Cristine. Would you be surprised in this case if it does not show an hippocampal sclerosis, or you are very much sure based on semiology that it is indeed hippocampal sclerosis?
Actually, I think it's a very, very because you see, so he had the febrile seizure in the first age, and then he had the silent period, and then he started with the seizures again in the adolescence. So it's very, very the history of the hippocampal sclerosis, because you have the first thing that, and the first the initial thing with the febrile seizure, and then you have the time to start with the very difficult to control seizures. So it's very, very the history is very, very common in hippocampal sclerosis. So I would say that 99%. My first hypothesis is the etiology is hippocampal sclerosis.
I would ask a second question. I'm really tempted to ask a second question as a surgeon. My second question is, if the MRI is normal, you can pitch in here. Would you, based on the semiology, would you be confident enough to put a CG only in temporal, or would you like to have a wider coverage?
I think I would like to do more investigations. If an epilepsy protocol MRI is normal, and we are picking up the ictal onset in the right mesial temporal lobe, I would like to do more investigations. Like, I would like to have an arterial spin labeling on my MRI. I would like to have a PET of the brain. I would, if possible, try to do an ictal SPECT before even thinking of SEEG. Now, suppose I find that all my non-invasive investigations, including my ASL, my PET, and my, the ictal SPECT is all right temporal, and that too anterior or mesial, I would, question why I would go in with the SEG, particularly in resource-limited settings, because we have an antecedent febrile seizures. We have typical seizures, which are typical of origin from mesial temporal. And we have all investigations showing that it is the non-invasive, including the video EG, ictal onsets, and the PET, the SPECT, and the ASL showing right temporal. Unless there are some red flags. And I think Cristine will talk about those red flags. So if there are red flags to suggest an insular involvement, or parieto-occipital or occipital involvement in form of visual aura or auditory aura for neocortex, I would not try to go in with the SEEG. Cristine?
Yes. Oh, it's the same, because it's very typical. The semiology of this case is very typical, but I think that the spread, like we mentioned, sometimes you have something that is coming from the behind and then go to the mesial temporal. But I think that in this case, the semiology shows us that it begins probably in the mesial temporal. And the other thing that you mentioned, Manjari, is that sometimes if you don't have all of these resources, so you have to think about it. And here, I think in our center, maybe in this situation, sometimes you go to another things if the MRI is negative, so and you investigate the patients, and sometimes we go before the resective surgery, maybe we go to DBS. So it's a further discussion, but I think that I agree with you.
This is Kawai.
Yes, Professor Kawai, I was about you.
Manjari, maybe I missed, but let me ask one question. So this patient had a history of the secondary generalized seizure other than febrile seizure, because that is also, if he didn't, that shows that is a kind of sign of medial temporal lobe epilepsy, and less the occipital parietal occipital focus.
Okay, so the childhood history of febrile seizures was more of suffered from a recall bias, and so really we had to because he came into us at 40 years of age, so there was a significant recall bias on the childhood febrile history validation. But the parents said that there was movement of both hands and legs. They did not recall any focality before the movements. So it is difficult to say that the febrile seizures were.
No. Not about not about the febrile seizure. After febrile seizure, did he have any history of generalized secondary generalized seizure?
Okay. No, there was no history of secondary generalized seizures. There was mostly, that would indicate, as you said, we have to think of a wider thing, temporal neocortex or parieto-occipital. There was no secondary generalized seizures. These were just focal seizures with impaired awareness. So FIA, focal seizures with impaired awareness with an aura, of course, indicating the onset.
Okay, thank you.
So now I will request my colleague Ramesh to present about imaging and neuropsychology. So Dr. Ramesh Dodamani is associate professor in my department. He is also part of our Center for Excellence for Epilepsy and MEG Research Center. And Ramesh, please go ahead with your presentation.
Thank you, sir. Thank you very much. And at the outset, I would like to good evening to everybody. Good evening to the distinguished panelists as well as the participants. So I will be presenting the imaging part as well as the neuropsychological assessment. Before going ahead with imaging of this patient, I would like to have a brief basic discussion on Epilepsy Protocol Mri. Although Dr. Antônio will be presenting in detail about this Epilepsy Protocol and other related imaging. So I would be presenting a basic details. So Epilepsy Protocol Mri, it as directed by the Neuroimaging Task Force by the AIIMS, it includes three specific sequences. That is, they are acquired in, it's called as the harness protocol, and they are acquired in 3D sequence, and it is recommended that it is to be done in 3 Tesla MRI. So the basic advantage of this is that the number of the duration of this sequences will take 30 minutes. That is 7 to 10 minutes for each sequence. So it is a 3D T1 sequence, which is isotropic and millimetric voxel resolution. This is basically important for analyzing the normal brain anatomy as well as the morphology. Next. High resolution 3D flare sequence, which actually attenuates the CSF, thereby increasing the visibility of cortical as well as subcortical lesions like focal cortical dysplasias, hippocampal sclerosis, gliosis, tuberculosis, and even hypothalamic hematomas. So this is very useful for analyzing the pathology. And a 2D sequence of coronal T2, high coronal T2 weighted imaging, where the slices are taken perpendicular to the axis of long axis of the hippocampus, and they are submillimetric voxel resolution. This is better depicts the internal structure of the hippocampus. These are the three sequences which are required mandatory for epilepsy protocol MRI as per the guidelines. However, in cases of suspected neoplasia, especially gangliogliomas, contrast scan would be recommended, apart from which susceptibility weighted imaging, which better detects the blood products as well as hemosiderin and calcium, would be recommended in patients suspected of vascular malformations, especially cavernomas. So this is an epilepsy protocol MRI. Again, I would like to reiterate that the details of, I will be just presenting the basic details, and Professor Antônio will be presenting in the next session. So here, the long axis of the hippocampus, the voxel is placed perpendicular to the long axis of the hippocampus, which is done in the sagittal plane, and the midline is adjusted based on the coronal as well as the axial sections. Next. So I'll be just giving a few illustrative cases where indicating why the need for epilepsy protocol MRI. The most important thing while evaluating an MRI is the MRIs should be visualized on the packs of the, they should be analyzed on the packs, but they should not be seen on a film or a single slice base. So this is basically important to rule out dual pathologies, especially in this illustrative case. You can see that there is a left-sided atrophy of the hippocampus along with dilated temporal horn, which is well appreciated in the T2 weighted images. Again, loss of architecture is seen on the left side. So the primary findings are hippocampal atrophy, increased signal intensity, as well as dilatation of the temporal horn. These are the secondary findings which may be associated with MTS, hippocampal sclerosis, like ipsilateral atrophy of the mammillary bodies, which is seen here. Next. And also there may be ipsilateral atrophy of the fornix, which is again supportive of the hippocampal sclerosis pathology. So in this illustrative case, this is a arterial spin labeling, which indicates perfusion of the temporal lobe. Here it indicates a low perfusion in the mesial structures, and this sequence especially can be done during the MRI as one sequence, although not recommended in the epilepsy protocol, but it is, if the facility is available, it can be done, and it is better suited for resource limited countries where PET scan is not available for evaluation. Although it cannot replace PET, but it has a value. So there are few imaging red flags. Again, these are illustrative cases showing dual pathologies where you have a left-sided hippocampal sclerosis along with associated anterior temporal lobe blurring of the gray-white junction, which indicates a presence of focal cortical dysplasia in the anterior temporal lobe. Another illustrative case showing a right-sided slight increase in hyperintensity of the amygdala compared to the left side, along with blurring of the gray-white junction of the right anterior temporal lobe with presence of right-sided MTS. So this is again a dual pathology, and this is another illustrative case showing bilateral MTS along with the left-sided anterior temporal focal cortical dysplasia. You can very well appreciate the white matter on the right side, and on the left side there is a blurring of the cortical gray-white junction. So these illustrative cases I have just placed basically to understand the importance of visualizing the MRI in detail rather than seeing just a snapshots, which usually in our setup at a peripheral center, they are performed as routine protocol MRIs, and they are very thick slices and seen by a general physician or a neurologist who is not trained in epilepsy. And they label it as normal, and that leads to the delay in the treatment as well as increases the financial burden, as the patient, again, when referred to a specialty center, will have to undergo repeat MRI imaging under epilepsy protocol. Coming to the current case, these are the imaging. This is a MRI 3D sequence done under T1 weighted images showing in this coronal section, we can appreciate the bilateral anterior temporal lobes appear to be normal. This is a hippocampus, which is on the right side. It is of smaller volume compared to the left side. Secondarily associated, there is a dilated right temporal lobe. Mammillary bodies, secondary findings like mammillary bodies as well as the ipsilateral fornices are normal. The rest of the brain appears to be normal. Again, the same findings we can appreciate on the axial sections, axial T1 sections. The anterior temporal lobe looks normal. There is no gray-white blurring seen. And again, hippocampal atrophy can be seen along with dilated temporal horn. You can go to the next slide, sir. So this is the 3D FLAIR sequence. There is no hyperintensities in the right side temporal lobe apart from the mesial structure, that is the hippocampus, which is hyperintense compared to the left side. Secondarily dilated temporal horn. The mammillary bodies look normal in size bilaterally, as well as we can appreciate the bilateral fornices, symmetric bilateral fornices. The same findings can be appreciated on the coronal FLAIR images. Another common association which we find is ipsilateral temporal lobe atrophy, which is seen in a few cases, which is again supportive finding for diagnosing hippocampal sclerosis. So in this case, there is, on examination, there is a slight temporal lobe atrophy as well. So we can see the classical right mesial temporal sclerosis, that is hippocampal sclerosis. There are no other abnormal findings apart from this. These are coronal inversion recovery sequence as well as the coronal oblique high T2 weighted sequences depicting the normal architecture of the hippocampus. You can see the loss of undulations of hippocampus on the right side compared to the left side. Again, in this sequence, we can appreciate the architecture of the hippocampus on the right side, where it is flattened compared to the left side, which has good undulations. Rest of the brain is normal. So coming to the normal imaging findings, which we can expect in a case of hippocampal sclerosis. Mainly there will be hippocampal atrophy, loss of hippocampal architecture, that is loss of undulations, increased signal intensity, secondarily dilated temporal horn, atrophy of the ipsilateral mammillary body is an associated finding. Again, atrophy of ipsilateral fornix as well as temporal lobe are associated with hippocampal sclerosis in most of the cases, which support the diagnosis. In our case, we have these positive findings, that is presence of hippocampal atrophy, loss of hippocampal architecture, increased signal intensity, as well as secondarily dilated temporal horn. All these features point towards a right-sided hippocampal sclerosis. We can play the arterial spin. This was the arterial spin labeling done in this patient, again, which shows a right-sided mesial temporal hypoperfusion compared to the left side, which is again a supportive finding.
Let us finish the neuropsychology and then we can take opinions from Dr. Rocha.
So on neuropsychology, he was right-handed with intact attention and average IQ. Visual memory was delayed, both immediate and delayed visual memory were impaired. Visuospatial constructive ability was also impaired, suggestive of right-sided temporal lobe involvement. However, immediate recall, delayed recall, as well as long-term retention were intact. So verbal memory was not affected, so, indicating a left normal temporal lobe function. We routinely perform ophthalmological evaluation, and in this patient, bilateral visual fields were normal. However, the rationale behind performing visual fields is that post-operatively, approximately in most of the studies, it has been quoted that 70% of patients develop left-sided superior unilateral superior quadrant anopsia. So it might have legal implications. So it's better routinely we perform at our institution at least that preoperative visual field analysis.
So here, before we proceed to the final conclusion, may I ask Dr. Rocha whether he has any comments on the radiology, whether he is happy with the radiology or would he like some other investigations?
It's a very typical case of hippocampal sclerosis, and it's very well demonstrated on imaging, on magnetic resonance imaging. And I don't know, there's nothing to do magician. It's a typical case, very good demonstrated.
So my question to you is, Dr. Rocha, let us say a patient comes to your center. He has just films which is showing thickened sections. It has maybe 5 millimeters thickness. So would you like to repeat an MRI in your institute with thin sections, or in your center would you be happy to go ahead with surgery if it shows hippocampal sclerosis?
I think there's no need, because this flare excision and the other excision is all in 3D isotropic. So you can reconstruct in thin sections in different planes, in different coronal planes or exoplanes. It's a very good demonstrated on these images. The examination is complete. I don't know. In my opinion, no need.
Thank you. Thank you very much. So we will come back to a detailed discussion. So maybe Manjari now can suggest what is the summary.
So of course, we have this patient here who's pretty much very straightforward, though we kept trying to look for the red flags of the semiology, which was suggestive of a non-dominant right temporal lobe involvement. The ictal onset suggestive of right anterior temporal lobe involvement, and also the imaging, which was suggestive of a right hippocampal sclerosis. We had 1 mm sections ruling out coexistent dysplasias or dual pathologies, and a neuropsychological involvement indicating a preserved function of the dominant left temporal lobe. With this, we pretty much were confident that no further investigations were required, and the patient was counseled for possible surgery and was also counseled for possible outcomes and the need of continuing medication for approximately an year following the surgery, and then gradual taper one by one after surgery, depending on his seizure freedom and his post-operative EEGs. So with this, we went ahead counseling the patient and the family about the surgery and went ahead with a surgery.
So my question to Cristine. So Cristine, in this case, patient had an intact verbal memory. Supposing he had an impaired verbal memory, what would you advise?
Actually, if you have the impaired verbal memory, maybe we could put the not resective, but maybe we could stimulate with DBS this patient, and maybe it would be something to do with him.
Okay.
I don't know, Arthur. Arthur, do you want to say what do you want to do then with him?
Yes. Now this is a question to Arthur and Professor Kawai. So if you have impaired verbal memory, now if DBS is too expensive for developing this, do we have any other options in this patient?
We have a kind of technology to preserve memory on dominant side called, namely, the hippocampal transaction.
That's right.
So in Japan, we still don't have the stimulation or laser ablation. So I usually select hippocampal transaction for those kind of patients. So it is not a resection, removal of hippocampus, but you transact the perpendicular to the hippocampal axis and preserve the hippocampal circuits with the entorhinal cortex and fornices.
Thank you.
You're talking about patients with right mesial temporal sclerosis and both verbal and visual memory impairment. Am I correct?
That's right.
Yeah. It's very common to have patients with both types of memory impaired in unilateral mesial temporal sclerosis, be it having it in a patient with left mesial temporal sclerosis and having also visual memory impairment, and people with like this one with right temporal that would have, this one doesn't have, but that would have memory impairment. Actually, if you look into a large series, what happens to the contralateral memory type is that it improved if you turn the patient into remission by removing the mesial temporal sclerosis. So it's very likely, for instance, that in a patient with left mesial temporal sclerosis who have both visual and memory impairment, if you remove the mesial temporal sclerosis on the left and he is seizure-free, that you're going to see in the follow-up improvement in visual memory. And the other way around, if you have a patient with right mesial temporal sclerosis that have both visual and verbal memory deficits, it's very likely that if you remove the right mesial temporal sclerosis and the patient is seizure-free, his verbal memory is likely going to improve. So I wouldn't be afraid of removing a clearly sclerotic hippocampus. In these patients with clearly sclerotic hippocampus, you are not going to induce any additional memory deficit because they already have the deficit related to this structure that is basically destroyed from a functional point of view. If you see such a mesial temporal sclerosis as you have in this case, it means that from a functional point of view, it's totally destroyed. It's not collaborating. So I wouldn't be afraid of removing this hippocampus, even if the patient has verbal memory deficits. The question would be maybe on the level, maybe an academic level, why they would have verbal memory deficits if they have right mesial temporal sclerosis, and this is not uncommon. And so first, you need to think about seizure activity invading the normal side, causing verbal memory deficit. And additionally, you could think of the etiological factors that caused right mesial temporal sclerosis to also have affected in some way the left side, which is also not uncommon because it's likely, you see it as unilateral, but many patients has non-symmetric atrophies of the hippocampus. So, but mainly, as far as we know, the contralateral memory deficit, if you see a normal hippocampus, is mainly due to spread of activity from the sclerotic one. I'm not worried about resecting this hippocampus there.
Thank you very much. So this is our plan, what we did. So right now we go in for faculty interaction. We've already started them. So it gives me a pleasure to introduce all the faculty here who would be giving a 10-minute presentation on semiology, radiology, and surgical approaches and outcome. So my pleasure to first introduce Dr. Cristine Mella Cukiert. She has a degree of medicine from Pontifical Catholic University of Rio Grande do Sul and a medical residency internal medicine at the same university, medical residency in neurology at the Faculty of Medical Sciences of Santa Casa de Sao Paulo, and a specialization in electroencephalography at Escola Paulista de Medicina, Federal University of Sao Paulo, Master in Medicine and area of concentration, clinical medicine from the Faculty of Medical Sciences from Santa Casa de Sao Paulo. So it's a pleasure to have her here. Just to consolidate whatever we have seen today.
Okay. Oh, it's very nice to be with you here. And I think that we've mentioned before, I think that COVID has brought many, many bad things, but the good thing is that we can be together and sharing with all people. And I think that the main issue is to improve the quality of treatment of our epilepsy patients. So I am very happy to be here with you. And fortunately, in some time we'll be together. Okay, so now we'll talk about mesial temporal semiology, as Manjari mentioned before. So we have to see some things that is very usual to this right temporal lobe epilepsy. So as we know, so we have mentioned the mesial structures and the neocortical structures. So today we'll talk about the mesial structures and the mesial semiology of temporal lobe epilepsy. We know that's different, so we have some different kinds of semiology when we talk about the mesial and we talk about neocortical structures. And sometimes we have some neocortical structures spreading to mesial, and then it can confuse us. So it's very important to know the initial part of the seizure to know what about. So when we go to the operational classification of the seizures, the 2017, so we have the focal onset, and as we know that we have with the aware and impaired awareness. So we'll talk about the aware seizures and we'll talk about impaired awareness seizures. When you talk about the temporal lobe epilepsy, that's work of Palmini and Glure in 1992. So they see that the most important and the most present seizures are auras, that we call auras, with the focal onset with the aware. So we see that we have the cognitive seizures and we have the autonomic seizures in this kind of patients. And the most important cognitive seizures that we see is the déjà vu, jamais vu seizures when it comes with the left temporal lobe, with this and also the memory impairment and the responsive impairment in this kind of patients. When we talk about the psychic or emotional or affective seizures, the most important thing that we see in the mesial temporal or temporal lobe epilepsy is the fear. Okay, and when we talk about the autonomic signs, we can see all of them, but the most important is the gastrointestinal or aura or gastrointestinal auras. When we go to the second part of the seizures, we have the automatism that we'll see before, after, and the motor part. Then we can have the rest or the tonic postures that we'll see. When we talk only about the focal aware onset seizures, we see that mostly 40 to 85% of the patients present with auras. But sometimes we have to remember that sometimes the patient cannot recall the beginning of the seizure because of amnesia. So sometimes they don't recall. But auras, personally, they occur in 40 to 85% of the patients. The most, so we have the abdominal sensation, the epigastric rising sensation, and also the ictal vomiting. And when we see the ictal vomiting, we can read the flag from the right or the non-dominant lobe. The cognitive auras, so we have the dysmonastic auras, like we mentioned, so we have some impairment of the memory, and then we have the déjà vu, mostly important in the non-dominant lobe, and jamais vu. So déjà vu is the situation when the patient has the familiarity with some situation that he didn't pass before, and jamais vu is the or oppositely the situation of that it's a usual situation, but he didn't, the patient didn't recognize this kind of situation. The other cognitive issues that we can find, so altered reality, some from most internal and external, from the possibility to interact with the environment. The aphasia that is dominant when we see it in the dominant lobe. The emotional, as I mentioned, so we have the fear, so with the compromission with the amygdala atrophy or something with the amygdala. And also the panic attacks, something that mimicking the panic attacks when the patient and when the patient had the autonomic and behavior changes in this kind of situation, we see that is the most predominant is the non-dominant lobe in this kind of situation. And this shows us the complement with the orbital prefrontal, anterior cingulus, and temporal limbic cortex. So these are the most important focal aware onset seizures that we see in the mesial temporal lobe epilepsy. Here I have a patient. Let's see if you can see this. Can you see the video? So this patient, she begins with some kind of sensation with here we can see the compromission of the right, and here she has the ictal vomiting. So all of this of her seizures begins with this sensation of aura and with nausea and vomiting, and then the proceeds the seizures. The other thing that is very important in this kind of patients is the dysperceptive or impaired awareness seizures. So after the aura, we have 70% of these patients, they have this kind of impaired awareness seizures. The duration of the seizure is from seconds to minutes, mostly from 30 seconds to 1 minute. And the loss of awareness, it points us to the involvement of both hemispheres. And this is seen by Jasper in 1964. But some other works, sometimes we don't have the involvement of both hemispheres, but mostly when we have the loss of awareness, mostly both of hemispheres are involved. Precipitating factors for this kind of seizures, as we know, so some distress, sleep deprivation, and catamenial period is very involved and as a precipitating factor for this kind of seizures. In the ictal period, we have the non-motor components like behavioral arrest and unresponsiveness, staring. So the person has the behavioral arrest, and then the staring, so with the fixed eyes. So, and then we also can have, like the case, some well-formed speech, like our case, so pointing to the non-dominant hemisphere. And when the patient has the ictalophagia, so it points to the dominant hemisphere and the complement with the limbic neocortical structures. In the ictal period, we have the motor signs. So the automatisms are we can see in 40 to 80% of the patients. If the patient remains reactive during the phase of the automatisms, it points us to the right hemisphere also, because we don't have the compromission of the language. So in these cases, most of the patients, 10% of patients can remain reactive in the phase of the automatism. The most important that we find mostly in this kind of patients is the oral alimentary, and also the manual, stereotyped manual automatisms that can be unilateral or bilateral. If they are unilateral, they point to the site of the initial onset. The unilateral dystonic posture was first described by Kotagawa in 1989, And he showed us that 25% of seizures, it has the dystonic posture, and that this dystonic posture that lasts for more than 10 seconds. And it's a forced limb posturing, and this reflects the propagating to basal ganglia. And when we see, like this patient I will show to you, so she has some unilateral, begins with a unilateral automatism on the right hand, and she has some, we'll see some posture of this finger and for this left hand. And then she will evolve with the right hand automatism again. And here you see the paralyzed, or this limb is paralyzed or removed, and then with this right automatism on the right hand. This kind of situation points us to the unilateral automatism and unilateral dystonic posture. The lateralization is 90 to 98% of the times. So it's a very, very strong situation that lateralize the semiology lateralize for the side of the focus. The other thing that we have in the motor ictal period is also the versive head turning. So the initial forced deviation of highs and red, they are ipsilateral to the focus, and when in the mostly to the end of the seizures, just before the generalized tonic-clonic seizure or the generalized bilateral seizure, because they initial force it to one side and then they move to the other side, and this sign before the propagation is 90% contralateral to the side of the initial seizure. Blinking also is mostly they are ipsilateral. Sagging, that is the person that can move to one side or to another side. It's not a lateralized signal. And another motor thing is the bilateral tonic-clonic. It occurs in 50 to 60% of the patients, and sometimes they are asymmetric. And we have the four signal posture, and maybe it's asymmetric. And the tonic posture is sometimes it's opposite to the side of the initial focus. Here, just to show, this is a very interesting paper from Kotagal from 1994, showing us that the things that occurs in the onset of the seizure, the middle seizure, and the last part of the seizure. And mostly we see that behavioral arrest, alimentary automatisms, repetitive automatism, it begins in the first part of the seizures. And complex gestures, it occurs in the last part of the seizures. And this is another interesting thing that we see, that sometimes we have the combination with 70% of the patients have the combination of two of these things occurring in a very nice situation that we occurring in clusters, like behavioral arrest plus or alimentary automatism or repetitive rand automatism. So it's almost 70% of the patients, they have this cluster of the two of these things occurring together. Post-ictal, so they could lateralize our situation also. So most of these patients that has the amnesia. The confusional state, if the confusional state or the rapid return to basal shows us that, or points us to the right hemisphere. Post-ictal aphasia points us to the dominant hemisphere. Nose whipping sometimes is ipsilateral to the focus. And I will pass this one. And I will show you this is another very interesting work that Dupont that show us that actually the most lateralizing feature that we can see in the semiology is the post-ictal aphasia. That is points us to the left lobe. And we have some red flags for temporal lobe. So when we see déjà vu, complex visual and auditory hallucination, we can think about the right lobe. Automatism with preserved responsiveness, so also we have to think about the right temporal lobe. When we have the well-formed ictal speech, automatism, ictal spitting and coughing, like we saw in this patient, we can think about the right lobe also. Ictal vomiting, that, as I show you, we can think, and rapid return to baseline. And the other thing that's very, very important to think is the spreading. So the spreading, because we have the initial onset, and we have to be very, very attentive to the initial part of the seizure and the initial symptoms. But it's very difficult because sometimes, as I mentioned, the patient has the patient can't recall the initial flag, the initial symptoms. So it's very important to have the familiar and the people that can see, or also if this patient has only auras with not spreading, with no going to the impaired awareness seizures. And the other thing is sometimes you have seizure that begins from the parietal lobe or from the occipital lobe, and spread to the mesial temporal. And sometimes the patient will talk about these mesial temporal symptoms, but we have to be very careful about this spreading that begins from the behind and go to the mesial temporal areas. So with this, I would like to finish, and thank you so much for joining.
Thank you very much, Cristine, for that very nice and lucid talk. So I would now request Professor Antônio Rocha to make the next presentation. He is the head of Division of Radiology from Sao Paulo, Brazil. Very well known for his work in epilepsy, has more than 113 publications. Particular areas of research include cerebral blood volume, epilepsy, pituitary imaging, DTI. And as you can see, we have tried to mimic this meeting as closely possible to an comprehensive epilepsy meeting. And that's the reason we have involved a neurologist, a radiologist, and a surgeon.
Thank you very much for inviting me. It's my honor to participate. And in the next few minutes, talk about hippocampal sclerosis, and I show you step by step how to use MR in this situation. And I'm sorry, I will repeat some information about this. It's not a déjà vu, don't worry, it's only repeated information. No conflict of interest. The first step is related to the protocol, and we use on daily routine, we use 1.5 Tesla MR scanner, but to obtain high resolution images in coronal plane, and this coronal plane is a peculiar plane adopted to the temporal lobes to get coronal images and resolution using iezotropic on T1, spoiled gradient echo, on T2, fast spin echo, and inversion recovery sequences using flare or short haul images. We use always these sequences to study the temporal lobe and the whole brain and the temporal lobe to obtain this high resolution images of the temporal lobe like this. 1.5 is usually used to do this, but the best option is using 3 Tesla MR scanner, because the definition of the internal structure of the hippocampus is better when you use 3 Tesla. The next step is to recognize imaging anatomy, and you can see that the images using high resolution T2 images is compared to the pathology is very similar, and you can define the zone or obviously the topography of CA zones, CA1, 2, 3, and 4, and also to define this dark line inside the hippocampus with the margin of the dentate gyrus. And this round structure is the hippocampus formation. It's completely different from the rest of the brain, and some peculiar zone affected in this situation with this kind of epilepsy. The rest of the temporal lobe, the mesial temporal lobe, is composed by the subiculum and the parahippocampal gyrus, limited by the collateral sulcus. This is very similar between the images, the T2 high-resolution images, and the pathological studies. The next step is to recognize, using high-resolution images and when you know the anatomy, to recognize imaging abnormalities that define hippocampal sclerosis. The pathological basis of hippocampal sclerosis is the neuronal loss and also gliosis. When you have neuronal loss, you have on images atrophy, hippocampal atrophy. When you have gliosis, you see on images increased water content, so more hyper-intense signal on these affected zones. You can compare the right hippocampus and the left one. In the right side, you can see normal structures in this roundy area, completely normal. The subiculum, the parahippocampal gyrus, and the collateral sulcus. In the left side, you can see the abnormal structures, internal structures affected with the hippocampal sclerosis. I don't know where's the line, the dark line, the dentate gyrus, and those zones that's affected in this disorder. And also you can see the atrophy in the subiculum and also in the parahippocampal gyrus less affected. FLAIR images on high resolution is better to demonstrate this increased content of water with hyper-intense that's clearly visualized. These abnormal internal structures is also affected and is clearly demonstrated in this kind of sequences. So, in the next step, you can compare the typical findings of hippocampal sclerosis with some others that will define red flags that will never occur in hippocampal sclerosis. Mass effect, gadolinium enhancement, calcification, hemorrhage, and restricted diffusion is none of them are related to hippocampal sclerosis. So if you have one of these, probably you have a differential diagnosis in your patient. Some of them can add to hippocampal sclerosis, and you can see a combination of findings. So, in the last step, the step 5, you recognize differential diagnosis of hippocampal sclerosis. If you see mass effect, it will you have a differential diagnosis not related to hippocampal sclerosis. Most of these cases are related to tumor, diffuse glioma, or also an inflammatory disorder, for example, limbic encephalitis. The next example is related to the breakdown of blood-brain barrier. That's the gadolinium enhancement. In it, you can see a focal lesion in the left side in the parahippocampal gyrus that is known as this kind of heterogeneous signal intensity on T2 and focus of gadolinium enhancement. It's not hippocampal sclerosis. The hippocampal formation is displaced superiorly and compressed, but it's a tumor. It's a ganglioglioma, another type of epileptic tumor in the temporal lobe, most common in children and young patients. The next one is the demonstration of calcification. If you have a patient with calcifications on CT or MR, in this case in MR, with black dots in the brain parenchyma, you can see two black dots in the left temporal lobe, and one of them associated with hippocampal sclerosis. This is hippocampal sclerosis, as we have mentioned, and this is the calcification related to neurocysticercosis. So the association with an infection and hippocampal sclerosis very well demonstrated on MR. And this is another association. We can see a hemorrhagic lesion in the right temporal lobe in the medial zone that's characterized by cavernous angioma and also associated with hippocampal sclerosis. It's not part of the hippocampal sclerosis. The hemorrhage is associated, is due to cavernous angioma. This is an association. This is a dual pathology. And the last one is diffusion weighted imaging restricted in the hippocampus. It will occur related to vascular disorders as a result of cytotoxic edema and with ischemia, or also a transient global amnesia. That's not part of epileptic syndrome, but another disorder related, situated in the hippocampus. So the last one, step by step, remember the MRI protocol, high resolution images based on T2 weighted images on the coronal plane, the specific plane perpendicular to the temporal lobe. And the next step, the anatomy, remember the internal structures of the hippocampal formation, and then you'll be able to recognize typical findings of brain internal structures of the hippocampal formation that's reduced and hyperintense. This is the abnormalities as a result of neuronal loss and gliosis, as a result is recognized as hippocampal sclerosis. But remember red flags and differential diagnosis that can be associated with epilepsy, or also it can be associated with, or not, with hippocampal sclerosis. Thank you very much for your attention. This is my presentation.
Thank you very much, Professor Rocha. That was a very lucid, nice, and exhaustive presentation. I now have the pleasure of inviting Dr. Arthur Cukiert, who is a surgeon, to finally present about surgery and outcomes, especially related to the right hippocampal sclerosis. Okay, so I would like to take the opportunity to thank Manjari and Sarat for the kind invitation. You know, we are always happy to be with you and have to congratulate on this new initiative. I think it's already a success, but it's gonna develop more and more. What I would like to do today is just discuss the surgical treatment options for temporal lobe epilepsy. Of course, it cannot be done. We could remain days discussing this, but does give you the options, and then maybe in the discussions we can dig into one of
the other techniques. So temporal lobe surgery, temporal lobe epilepsy can be treated by a variety of techniques. They can be resective or ablative, disconnective or neuromodulatory. And we are going to talk a little bit about each of these ones, except for focus ultrasound, which is still in development. Focus ultrasound at this point can treat the lesions in the midline, like making lesions in the thalamus for tremor, or treating hypothalamic hamartomas, which is a midline lesion. But far more lateral lesions are not yet possible, but it's being worked out, and I think in a couple of years we are going to be able to do more lateral lesions using focused ultrasound. This is just to show you our series and may say that we still do more resective surgery than modulatory surgery, but modulatory surgery is increasing in frequency. And if you think about resective procedures, temporal lobe resection is still the major type of procedure that we do in epileptic patients. So it needs to be mastered in any center dealing with epilepsy surgery. Anterior temporal lobectomy, or more better said, corticoamygdala hippocamectomy, is the procedure. It's the gold standard. Again, the procedure against all the others need to be compared. And the analogous to anterior temporal lobectomy would be the selective amygdala hippocamectomy techniques. As you can see here on the right, the hippocampus is at the tip of the orange arrow here, and all these red arrows are the types of procedures that have been tried to reach hippocampus and resect it. Each technique was developed in a different center, and some of them get names after it, like Olivier techniques or Yazagil techniques or Niemeyer techniques. But the idea is all the same, to enter the temporal lobe and resect the hippocampus. As you can see, except for this very last arrow down here near the orange arrow, all the other procedures to reach the hippocampus cut through this bundle of white matter here that is inside the yellow circle, and meaning that they cut through the temporal stem, which is the structure that carry all the fibers coming from the cortex. And then calling is selective. It's called selective because it doesn't remove the cortex. But from a functional point of view, except the one coming from the subtemporal approach, all these procedures also have functional impact on the cortex, or not. They are not functionally selective, but they are anatomically selective. Mesial temporal sclerosis is the main etiology for temporal lobe epilepsy, and is the one which yields the best results, to which all the other procedures will need to be compared. And you can expect up to 85 to 90% of the patients being seizure-free after surgery in patients with mesial temporal sclerosis. And 77 or 75% of them without any seizures, including focal aware seizures. So this is the gold standard that all the others would need to be compared. It's such a known pathology that if everything is unilateral and congruent, many of these patients can skip a video EEG recording, although if it has any non-congruence, we need video EEG recording. There were a number of systematic reviews comparing corticoamygdala hippocamectomy to selective procedures, and most of them didn't find any difference in seizure control, though some found better results in corticoamygdala hippocamectomy against the selective. But this is in adults. It's right now very clear that although in adults they can have the same results, in kids, corticoamygdala hippocamectomy or standard temporal lobectomy had better results than selective procedures. So adults, you can do whatever you want, but in kids, you definitely need to go for a corticoamygdala hippocamectomy. If you intend to perform a non-selective procedure, because if you intend to perform a selective procedure, there's no other concerns other than anatomy. But if you intend to perform corticoamygdala hipocampectomy, you have two major concerns. If there is a value of using intraoperative electrocorticography and how much cortex you have to resect. Most of the meta-analysis to date shown that intraoperative electrocorticography is of no great value in people with mesial temporal sclerosis, and then you can do the procedure without electrocorticography. Regarding the amount of cortex you intend to resect, there are two ways of doing it. You can measure linearly from the tip of the temporal lobe, and you're going to be resecting more on the left and less, more on the right and less on the left. Or you can use what we prefer to use is the position of the central artery, which is fixed phylogenetically regarding the anterior and posterior commissure and the rest of the brain. So you know that in front of the central artery, you don't have speech, so you can do it very safely. So you can either measure linearly or you can use a proportional structure like the central artery to do it. Other procedures that can be done are not microsurgical, they are stereotactic procedures. And this one is stereotactic thermocoagulation amygdala hipocampectomy made by radiofrequency. Radiofrequency is a very old technique in neurosurgery. We know everything about how the lesions are performed, how the size of the lesion, and etc. And this it's not new. It has been done in Japan and other parts of the world. But this is a paper coming from the Czech Republic, where they perform stereotactic radiofrequency hipocampectomy, and they have a result of around 70% of the patients in angle 1. It's definitely below corticoamygdala hipocampectomy, but it does compare with the next new kid on the block, which is LIT. And if you can see, even the type of the lesions in radiofrequency and LIT, they're about the same. The advantage of LIT is that it can counsel the use of thermal control, intraoperative MR thermography, so you can kind of see your lesion being done, and you can control better for it than if you do it with radiofrequency. This being said, there is no direct head-to-head comparison between radiofrequency and LIT at this point, and I think this is something that's going to happen in the future. There are some small differences in the type of lesions that arise from LIT or radiofrequency. The LIT lesion being a little bit more defined than the radiofrequency. The penumbra area in the radiofrequency lesions are larger, but how this would impact in outcome is not to be seen. What is happening, especially in the US, for instance, is that people are preferring to go for LIT before corticoamygdala hipocampectomy because it's considered a less invasive procedure. Again, it's the number of procedures in US, which is the only place in the world where they have larger availability of LIT, is increasing toward the direction of LIT, but this is major apparently driven by patient preference. And we don't know if in the follow-up is still quite small, so we don't know which will be the end result of LIT compared to corticoamygdala hipocampectomy, but this is simply something that we need to do and compare LIT with corticoamygdala hipocampectomy and LIT with radiofrequency lesions. The other type of procedure is SEEG-guided radiofrequency coagulation. It's similar to radiofrequency that is shown from the Czech group, except that it's done using the SEEG electrodes themselves. This has the disadvantages of not being able to control for lesion size because there is no thermocouple in SEEG electrodes, and the lesions that are created by SEEG-guided radiofrequency coagulations are pretty small, as you can see here. And if put it in perspective, it's from the beginning, the results of SEEG-guided radiofrequency are worse than that compared to anterior temporal lobectomy. And I believe that there is very little role for SEEG-guided radiofrequency coagulation in these patients with mesial temporal sclerosis. Radiosurgery is another option. Nick Barbaro led a study comparing radiosurgery versus anterior temporal lobectomy. As you can see, the end result of radiosurgery was worse than that compared to anterior temporal lobectomy. It takes time. Effects of anterior temporal lobectomy is immediate. It takes time. But the most expected results were related to the eventual preservation of visual function and neuropsychology in these patients. But again, these patients did not show any better results regarding visual impairment or neuropsychology. So it's radiosurgery can be used. As you see, there is radionecrotic aspects during the long-term follow-up of these patients, though the end result is good. But radiosurgery should be reserved for very specific cases that are contraindicated for the other types of treatment. There are other interesting proposals. The group from Mario Alonso in Mexico proposed paripocampectomy without hippocampal resection. And this was suggested by taking into account the importance of the parihippocampal region in the genesis of mesial temporal seizures. The percentage of parihippocampectomy patients being seizure-free is definitely lower than anterior temporal lobectomy or even to selective amylohippocampeectomy. And then this might be reserved for some patients where memory is a concern, although we are not sure yet if parihippocampal resection would not lead to memory impairment also. Amylohippocampotomy, not hippocampectomy, but hippocampectomy, meaning that you disconnect the structure but don't remove it, has been proposed by our colleagues in Portugal. They did it in several patients and with a high number of patients seizure-free, but it's not clear yet how complete hippocampotomy impact on the hippocampus itself, because if you do it creating a large cleft like you're seeing here, you're actually cutting the vascular structure of the hippocampus and damaging it anyway. So we don't know if the effect of hippocampectomy is actually the same effect of hippocampotomy is not the same effect as hippocampectomy. As mentioned before, there is hippocampal transection, which is a procedure that has been proposed for memory sparing in patients who has normal memory and more likely in the dominant hemisphere. And some centers, it began, I believe, in Japan, but this one is published by a group in Canada, though the images are from Moreno. They did have some patients with good seizure outcome. It's not clear yet if in the long term the seizure control would be good or not, because you are actually not disconnecting the whole thing. I just want to finish by talking 1 or 2 minutes on neuromodulation for temporal lobe epilepsy. VNS, vagus nerve stimulation, is the oldest neuromodulation technique. It's an intracranial, extracranial surgical modality. And as you can see here, it yields a very low seizure freedom rate in patients with temporal lobe epilepsy, something like near 7 to 8%. It is an option. The other ways of treating temporal lobe epilepsy using neuromodulation are the use of anterior nucleus of the thalamus stimulation, responsive neurostimulation, and hippocampal DBS. As you can see, responsive neuronal stimulation and deep brain and ANT, anterior nucleus of the thalamus, deep brain stimulation, have very, very similar results, with around 15% of the patients getting seizure-free, though most of them improved. And at this point, hippocampal DBS, continuous DBS, has shown a stronger and more robust response of the patients, with more up from 35 to 50% of these patients getting seizure-free. Just to summarize the neuromodulation options, as you can see here, the seizure freedom rate for VNS is the lowest, which is bad news because it was an option for patients who have failed temporal lobe surgery, for instance, but the seizure-free rate is very low. And the other options, ANT and RNS, are similar, and the hippocampal DBS is definitely the more robust results. I hope I have given you a whole view of this scenario, and we can dig into the specific techniques in the discussion as needed. Again, Manjari, Sarat, thank you so much for letting us share this with you.
Thank you very much, Arthur, for that very nice and elaborate presentation, making it very clear regarding the surgical options. To have a closure, we will now show you the histopathology and a brief surgery of the brief video of the surgery that we did, and this will be followed by question and answers, which will be taken up by Professor Kawai. And there is a housekeeping announcement. So all delegates who are watching this, you can download your certificate because this option is there. You can clearly see it there. The poll option is to be used in the end, where you can punch in your answers and we can see the overall response in form of a graphical display. So we will briefly present about the histology, very briefly about anatomy, just to have a complete closure of the topic, and embryology, followed by a video of the surgery, and this will be done by Dr. Raghu Samala. Dr. Raghu Samala is our fellow in epilepsy and functional neurosurgery, and he has completed his fellowship from our institute, and he will be doing this presentation.
Good evening to the panelists and all the delegates, and I thank you AIIMS AO subsection for giving this opportunity. The histopathology, I must thank Dr. Ramesh and Dr. Antônio for making my job very easy. And this is the histopathological slides of the patient, which are hematoxylin and eosin strained. The first three shows the lower field view, and the fourth one shows the high field view, in which there is a neuronal loss in CA4 and CA3 along with the dentate gyrus. And in the last high field image shows there is a neuronal dispersion with the loss and ischemic changes. Next. The histopathology slide at another level shows the neuronal loss in CA1 and along with some loss in dentate gyrus, suggesting the type of involvement of all CA regions, like CA1 to 4 and the dentate gyrus, which is a classical finding of hippocampal sclerosis type 1. These are the histological features that can be seen in a hippocampal sclerosis. As we see, there is a loss of neuronal loss in CA1 region and CA4 region, and there is a sharp demarcation between subiculum and CA1 and the mossy fibrous sprouting. So these are the patterns of hippocampal involvement in hippocampal sclerosis proposed by AIIMS Task Force Commission in 2013. The most classical one, which is also called classical hippocampal sclerosis type, which is type 1, in which there is predominant CA1 or along with the CA2 and CA3, C4 involvement. It is usually seen majority of the patients, and these patients present early, like a younger age group, and associated with the febrile seizures, and they have highest rate of seizure freedom. But it's coming to seizure, it is type 2 and type 3, they involve predominantly CA1 alone or CA4 alone. They present at the older age and the poorest post-surgical seizure outcome. So this is just to build an anatomical orientation in the upcoming surgical video, which next one, this is an animation video taken from Neurosurgical Atlas. It shows some animation. So this is seen medial structure seen from the medial side. There is a parahippocampal gyrus, dentate gyrus, and the forehead of the complex. This again from the lateral to medial when we open the ventricle, the various structures seen. And the most medially, after when you reach the arachnoid or tentorium, there is a very important structures like brainstem, posterior cerebral artery. Embryology of hippocampus is important for the two reasons. One is to understand the anatomy. Another is to understand the developmental anomalies that appear on MRI. The hippocampus starts forming at the age of 13 to 14 weeks of gestational age and completes by adult structure by 20th week of gestational age. The hippocampal plate forms the medial and floor of the hippocampal temporal horn. And as the neocortex expansion happens, and there is a differential growth of the various sub parts of the hippocampus, and there will be folding at hippocampal sulcus. This the diagrammatic imaging of the final formation shown in the below. It is important in an embryological point of view. There is the structure remaining. If the hippocampal sulcus remains intact, there may be a cyst formation, which can be a differential diagnosis for the hippocampal sclerosis. Usually, it is not associated with the epilepsy. However, it has mass effect. So these are the intraoperative specimens that are shown. The first image A shows there is a after lateral disconnection of the hippocampus and medial retraction, we can show the dentes gyrus and fimbria, and we can see the head of the hippocampus. And the figure B shows the complete removal of the hippocampus from the head to tail, which is important for the histological analysis. And the C shows the dentate gyrus, and D shows the arrangement of dentate gyrus in the CA region of the hippocampus, over which there is a alveus, the white matter fibers of the hippocampal head. So these are the arterial supply. The anterior head is supplied by the anterior hippocampal artery by the anterior arachnoidal, anterior choroidal artery, and the middle and the posterior hippocampal body is supplied by the PCA, P2 PCA, and it forms a long axis, longitudinal axis along the hippocampal body. It is also important to know the connectomes of the hippocampus, as the semiology was emphasized by the Professor Manjari Tripathi and the Professor Cristine. The connections of the hippocampus are very important to see the chronological order of the clinical semiology, and for this the connectomes are very important. So the important connectomes illustrated here are the blue one, which has the strong connections with the ipsilateral occipital lobes, and followed by the yellow, which is the cingulate gyrus, and the orange shows the spinal limbic pathways, which the head version movements can be explained by that, and the purple and green shows anterior commissure and the farneseal fibers. So there are various mechanisms posed for the etiology of hippocampal sclerosis: the genetic causes, the prolonged seizures, induced neuronal loss, inflammation, and the maldevelopmental etiologies. So the most important pathophysiology proposed for epileptogenesis by various causes is mossy fibers sprouting into the molecular layer of dentate gyrus. And this is the most prominent feature of the hippocampal sclerosis, along with other biochemical parameters like reduced neuropeptide somatostatin neurons or increased somatostatin co-expression, or the brain barrier dysfunction, etc. So volumetry, I will give you a very brief about the volumetry. This is useful when there is a MTS findings are very subtle, and there is visually you can't perceive any hippocampal atrophy and visual inspection. So this volumetry helps in the superior detection of the hippocampal sclerosis. So this studied that the role of hippocampal volumetry in 37 patients by Gloria et al. They proposed that it was seen that the hippocampal volumetry is superior when compared to a experienced neuroradiology in terms of specificity and positive predictive value. Now I hand over to Professor Chandra for a proceeding surgical part. Thank you very much.
So this is the diagrammatic representation. So as shown in the histology by Raghu, it is very important that the hippocampus should be removed in toto. It should never be removed piecemeal. And that is the reason it has to be disconnected first laterally along the collateral eminence, and then mesially along the dentate gyrus, and then finally from the tapetal fibers. And then it has to be removed in toto. So we have a short video which will give you an idea. This is about the anterior temporal lobectomy with amygdala hippocampectomy. It's a 29-year-old male with focal onset partial epilepsy, showing a typical hippocampal sclerosis, which was discussed in this case. Now, this is a surgical incision which we give. Now, one can do a large craniotomy, but we prefer to give a curvilinear incision. And this is given along the line which is joined along the orbitomeatal plane, and another line joining the junction of the anterior 3/4 and the posterior 1/4. And we close the skin in a subcuticular manner. So we provide a semi-linear incision. So that is how we retract, and we open the muscle and fascia, and we prefer to operate through the 3 centimeter incision. Now in this case, as shown on the incision, let me go back because this is a bit important. Yes. So here you can see that this line is the junction between the frontal lobe and the temporal lobe. So when we give this incision, 2/3 of this incision is below this line and 1/3 is above, in which case we will have most of the exposure of the temporal lobe and maybe a small part of the frontal lobe. So in this way, using a very small opening, we are able to do a complete anterior temporal lobectomy with hippocampectomy, amygdala hippocampectomy. But my suggestions to new surgeons is please use a generous craniotomy if you are new to the anatomy. So this is the T1, T2. We always do a recording. So in the first, we do an anterior temporal lobe resection. This does not include the hippocampus or the temporal horn. It just provides us space so that we will have enough space to identify the temporal horn. The temporal horn now is identified by going along the inferior surface of the sylvian cistern arachnoid. So we follow that mesially, and that directly leads us to the temporal horn. So now the temporal horn, the line of resection, we have to do lateral disconnection, medial, anterior, and posterior disconnection. The lateral disconnection is along the junction of the collateral eminence. Posteriorly, we go along the tapetal fibers, and we are doing the transgaryetal aspiration. This is the medial hippocampal disconnection. I prefer to use a pen-field dissector, number 2 or number 1. And then it is important to peel off the hippocampus gently from the arachnoid. Now this is the most crucial part of the surgery, where the sleeve of arachnoid containing the hippocampal arteries have to be slowly peeled off from the hippocampus. I prefer to do it using a suction and bipolar forceps. And now we are doing the posterior disconnection. As per the study by Weiser et al., it has been shown that the posterior disconnection has to be taken till the level of superior colliculus. And that's how the hippocampus is removed. So once it is removed, we then go along the tail and go back as far posteriorly as possible till the level of superior colliculus. Now there was a question from the audience whether this is to be dictated by the MRI. No, we don't use it as per the MRI. So as a policy, we always go as far as posteriorly as possible till the level of the superior colliculus. At the end, this is what we find. We find the P2, the third nerve, as well as the MCA. And the DVA is closed in a watertight manner, and we put the circular bone flap using mini plate and screws. And we apply subcuticular sutures so that the patient has good cosmetic outcome. And these are the post-operative images. So now I will request Professor Kawai to take up the question and answers. And following this, he will ask the MCQ questions. So I request all the audience to stay back for this interactive session. Professor Kawai.
Okay, I'll take answer the questions. The first one is sometimes verbal memory impaired due to secondary generalization, who then improve in verbal memory after the right surgery and ensuing seizure freedom. So actually, this is not a question but a comment. But yeah, it's true. And maybe this question is directed to the Cristine.
The improvement of memory after the surgery, when the person has the tonic-clonic generalized, is this?
Yes.
No, as Arthur mentioned, I think that we see in our patients, in some patients, when we remove this sclerotic hippocampals, the memory, we free them the other hippocampals, so the memory it gets some improvement. So I think also with generalized tonic, or especially with the very, very high frequency of this impairment seizures. So when we remove this bunch of seizures, patient gets some better memory.
Yeah, and I think in this case we also think about the time course. Usually, the improvement, so the decline and improvement after secondary generalization is usually more short term. Even if in longest case, it's about 6 months. So maybe we can differentiate the change, the reasons.
Yes, and then the other thing that we don't have more generalized tonic-clonic seizures, the bilateral tonic-clonic in this kind of patients. It's very, in our series, it's very rare to see. Only if the patient don't take his medication or things like that. But it's very rare to have the tonic-clonic bilateralization after surgery.
Okay, thank you. And next one is so what is the role of DBS in the case with right medial temporal sclerosis and bilateral memory impaired? This means maybe visual and verbal memory impairment. I think this the question is directed to the Arthur.
Yes, I think so.
Yeah, I don't think DBS is a primary treatment for people with unilateral mesial temporal sclerosis, be it on the left or be it on the right. Although I think DBS has to be considered if patient has temporal lobe epilepsy and normal hippocampi on the MRI. So the only reason I think a person with right MTS would undergo DBS is patient preference. Some of the patients are not willing to have their brains resected, and they can choose either laser ablation or radiofrequency thermocoagulation or DBS. Since DBS is a non-lesional procedure and totally reversible, we would prefer DBS, but of course, if it's a patient like this one presented today, I would strongly talk to the patient and try to convince him that what has been done is the best for him. But we do have patients that they say, "Hey, doc, I'm very sorry, but no one is going to open my head and take part of my brain." So, and then you have to give them the options. But DBS is not the primary treatment for unilateral right mesial temporal sclerosis.
Okay, thank you.
Also, the seizure outcomes would differ. With a resective surgery, the outcome is, better than DBS. In DBS, you really do not know what the response would be in a given patient. So wherever there's a lesion, you've counseled the patient, sometimes the irritative cortex on one side could actually be responsible for suppressing cognitive functions on the other side. So just removal of that mischievous cortex, lesion could result in improvement rather than worsening.
Yeah, I think we know how patients are going to respond to DBS. The problem is that we are seeing rarer and rarer cases such as that was presented today. Our patients, we don't see very frequently unilateral clear-cut mesial temporal sclerosis anymore. Our patients, most 90% of our patients have perfectly normal MRIs, and they have to a much more confusing and hard workup to do. And then you might imagine that things like neuromodulation are going to be used more and more in these patient populations with normal MRI. But I think there might be a consensus that if you see such a good candidate as is seen today, resective surgery is the best choice.
And actually, the author in your case series, the normal hippocampal cases had a better outcome than the hippocampal sclerosis cases, right?
No.
After DBS. No?
There is one series coming from Mexico City, from Francisco Velasco, that suggested that people with normal MRI would respond better than people with mesial temporal sclerosis. In our series, both of them responded in the same way, except that people with mesial temporal sclerosis needed a higher intensity, likely related to the atrophy and the dysfunctional connectivity there. But you could do it, and the fact is that if you have mesial temporal sclerosis, I will always try to convince the patient to have a resective or ablative procedure of any type, because I know the results are much better. But if not, or if the MRI is normal, you need to give them options.
Okay.
Sometimes we miss anterior temporal pole encephalocele because the section may not pass through that. And it has been seen that in patients where the semiology is very temporal, and particularly anterior and mesial temporal, this encephalocele has been missed. So, really the imaging protocol should, go right up to the anterior tip, and we should look at all the sections to make sure that the so-called normal hippocampal is not actually some other pathology.
Yeah, that's right. That is an important thing. Yeah.
Another issue, another warn maybe, it's that even if you have normal MRI, if you go into pathology, 15 to 25 of these patients still have mesial temporal sclerosis that it's not diagnosed by even the best MRI you can get. I have seen 7 Tesla MRI, 3 Tesla MRI, normal hippocampus, and then come pathology with mesial temporal sclerosis. So it does means that the probability of having mesial temporal sclerosis is very low if you have a normal MRI. But there are still patients that have mesial temporal sclerosis, but this is a different type. It's mostly those patients who have what they call the end folium sclerosis. It's a sclerosis based on CA4 and around the hilus of the hippocampus, and not the whole thing as the mesial temporal sclerosis as likely you've seen in these patients. But again, it's a red flag. If you have a normal hippocampus, it's a red flag, but it doesn't exclude totally that the patient still has mesial temporal sclerosis.
Okay, thank you. And the final question we take, how to differentiate fear and panic attacks? This is for Manjari and Cristine.
Just to point out, fear is what we have from COVID. Panic is what we have from our government, right?
I think that fear. So the person has some fear from an unexpected fear. Is a fear from nothing that's real. And when the patient has the panic attack, so the patient has some another vegetative symptoms like tachycardia and like hyperventilation. And so I think that we can differentiate. But mostly the panic attacks maybe begin with the fear sensation. Don't you think, Manjari?
In terms of seizures, fear generally represents, origin from the amygdala. So this has been shown in a series published in the Green Journal Neurology, that amygdalar origin is probably, amygdala network involvement is important in the generation of fear. And as you said very correctly, that fear is a perceived, sensation, which is subjective, and the expression shows on the face. Whereas panic is associated with other visceromotor symptoms in terms of, even restlessness, nausea, vomiting. You can have during panic, and all of us have had panic attacks during our exams, during medical studies. I had a severe panic attack during my first seminar. I still remember that. So panic is associated with lot of visceromotor symptoms, sweating and palpitations and nausea, vomiting, restlessness, sometimes even crying, and sometimes visiting the loo very frequently because there is anxiety and panic. So really you can differentiate both these, and panic can be seen as a part of the temporal lobe semiology also.
Yeah.
Okay, thank you.
I think we have covered everything. So Manjari, would you like to add a few comments before we close?
Yes, of course. It's been a wonderful evening of just focusing on, things related to only one case. Am I allowed to share some slides, Dr. Chandra?
Okay, yeah.
Okay, so we've really focused just on the non-dominant mesial temporal sclerosis, and it's difficult really talking about surgery or an approach to surgery just based on the single case. However, with the series that Dr. Kawai and Dr. Chandra have planned, each month, the first Saturday, would be dealing with a different case. So next month, we will go on to dominant temporal lobe, mesial temporal lobe. Then it will be neocortical temporal, then temporal plus, then pseudotemporal, then frontal, then parietal, occipital. So all the areas will be covered case-wise. However, the present series is to sensitize people who have not started surgery. It is essential that reading be done. It is also essential that experience be gained by working at centers under fellowship programs where cases are evaluated and operated under the mentorship of, teachers. So training, so learning involves not just attending a series, but also getting trained with a mentor in a fellowship program for epilepsy and epilepsy surgery, whether it be a neurology, a neurophysiology fellowship, or a surgery fellowship. So these series are just to generate interest and prime and have a fun way of learning about different kinds of drug-resistant epilepsies, which could be surgically amenable. We had about 800 registered participants. We had excellent speakers who I must thank. So I thank each and every registered participant from all across the globe. And I thank each and every speaker and panelist here. I thank the International League Against Epilepsy, particularly the Asian and Oceanian chapter. I thank Banks Backstage for technical support, which was seamless and without any interruptions, envisage ideas, Jignesh and his team. I also thank our unrestricted educational grant from Ipca Pharmaceuticals. If it was not for them, we would probably not be able to host a 700 to 800, up to 1,000 participant panel live by, within ourselves and generate budgets, etc. So this was unrestricted educational support which we got from them. So with this, I'd like to conclude the program, and please do look forward to the next, case, which would be left mesial temporal sclerosis. I also would like to let you know that the recording will be available, and we will inform you by email where the recording, on what link the recording will be available subsequently, so that you all can watch the program whenever at your free time and kind of revise, or you can ask others to also, some of you must have not been able to attend because of the weird time zones you're in. So the recording will be helpful to them. With this, I'd like to thank all of you and the AIIMS AO, Dr. Ikeda, Dr. Dunne, Dr. Chandra, and Dr. Kawai. Thank you.
Thank you. So would the faculty would like to say anything? Cristine, Arthur, Rocha?
Oh, I think it was very, very interesting initiative, and then I'm very happy again to be with you, and everything that you need, we are here to help and possibly to be together, everybody together again. Bye.
Thank you.
Antônio, are you saying something? Or?
Thank you. Only this.
Yeah, it's I have to congratulate you again, Sarat. I think it's a wonderful educational idea. It goes directly in what we are thinking on the recently founded International Epilepsy Surgery Society, which you are part of. So I think it's gonna grow and needs to be done more and more. Congratulations again.
Thank you. So I will request Professor Kawai to conclude by saying a few words.
Yes, so every participant, for us, it will be a great pleasure if we can help you start the epilepsy surgery program, particularly in countries and areas where you do not have yet the sufficient epilepsy surgery program. And I really thank the Cristine, Arthur, and the Antônio for your help from the opposite side of the earth. Thank you very much. And finally, I really applaud the Dr. Sarat, Chandra, and Manjari, Tripathi's the effort and great effort to organize this the first the webinar, epilepsy surgery case by case, step by step. This was a really great start, and I really thank you, and I really want to applaud. Thank you very much.
Thank you. Thank you so much, Dr. Kawai. So we close the session now. It was great having all of you. So wish you having a lovely weekend and a safe weekend. Till we join next time for management of dominant hemisphere pathologies, dominant temporal lobe.